Right. Pull up our notes here. All right, so thank you everyone for joining us today. My name is Lena, and I'll be the coordinator for today's session. Thanks again so much for joining us. Um, so this is the third session of the second series of our PPCL perinatal echo program. We're going to go over a few housekeeping items before we get started. So today I'll be coordinating. It's typically Jody West, but she's out in the field today, and Dr. Olivier is not able to facilitate the session today. So many big thanks to Dr. Finelli for stepping up and helping us facilitate the session today. So this is our agenda, and we'll do our best to adhere to this schedule. After I complete the following announcements, Dr. Finelli will lead us in introductions, and then Dr. Vincent will then present our didactic today. And then after she presents the didactic, we will then move on to our case presenter, which is presented by Dr. Anna Brewer. And then after Dr. Brewer presents, we will open the floor for any clarifying questions, first from all of you guys as the community participants, and then from our hub team. And then once all of the questions have been answered, we'll transition to providing some recommendations. And then after that, Dr. Finelli will briefly summarize all of those recommendations, and then we will wrap up with our announcements and close out the session for today. So now I'll go ahead and I'll pass it along to Dr. Finelli, who will facilitate our introductions today.
Thank you, Lena. Hi, everyone. I'm Juliana Finelli. I'm a general psychiatrist and a child and adolescent psychiatrist. My focus is perinatal psychiatry and infant and early childhood mental health. And I'm on the hub team as a perinatal expert, and also get to work with the PPCL team as a perinatal psychiatry consultant. And I'm stepping in for Dr. Olivier today. We'll miss her today, but I'm stepping in as facilitator, trying to keep us on time, fielding questions, summarizing some recommendations. And so I'm going to actually ask the rest of the hub team to introduce themselves as well. Dr. Paulazina, if you would introduce yourself.
Good afternoon, everybody. I'm Dr. Paulazina. I am a pediatric nurse, my original training in pediatric nursing, and also a clinical child psychologist. I work at Tulane in the Department of Psychiatry and Behavioral Sciences. I'm on the hub team and as representing nursing, but also psychology on our discussions around perinatal mental health. Thank you.
Thank you, Dr. Zina. I'll turn it to Katie Abear, if you would introduce yourself.
Hey guys, my name is Katie Abear. I am a social worker and perinatal certified. I work in private practice in Lafayette, Louisiana at Blue Mental Wellness. And my practice here focuses on the perinatal population. Thanks for having me.
Thank you, Katie. Thanks to everyone again for joining us today. And before we begin the didactic, Lena is going to tell us a little bit about PPCL.
Thanks, Dr. Finelli. And so again, my name's Lena. I'm one of the mental health consultants with PPCL. And if you haven't heard about us before, we are a no-cost mental health consultation program that is available to pediatric providers. So any provider that sees and treats children ages 0 to 21, and any OB providers that see and treat women in that perinatal period. You guys are able to call us if you need resources for your patient or guidance about mental health. So that includes screening, access to resources in the community. We also have perinatal and child and adolescent psychiatrists that are available to assist with questions about medication management and other diagnostic concerns. And we also host these echoes. We have a pediatric echo that occurs once a month, as well as this perinatal echo that you're attending here today. And we usually have some other webinars throughout the year as well. So if you're interested in getting updates about the program, just scan that QR code and it'll take you to our registration page. And that's about it. And so I think at this time we will go ahead and just jump right into our didactic presentation with Dr. Vincent. So Dr. Vincent, I will advance the slides for you and you can begin whenever you're ready.
Okay. I'm ready. And I'll just introduce myself briefly. So I'm Megan Vincent. I am a general psychiatrist and also child and adolescent psychiatrist. I am one of the perinatal psychiatry consultants along with Dr. Finelli for PPCL. And also have a private practice in New Orleans where I focus on treating older adolescents, young adults, and the perinatal population as well. I am going to thank Dr. Finelli as well for a lot of the slides in this set that I've been using for a while, but she used before me. And I'm also just going to give a general, I understand that we have a variety of disciplines represented here, and even though I'm going to talk about pharmacology, I have about 15 minutes to give an overview of a very broad, in-depth topic. And my goal is not to make everyone here master psychopharmacologists in pregnancy. That's not my intention. But I think given the populations that we work with, and a lot of folks, maybe hearing things when they're working with our pregnant and breastfeeding patients, that may just help to provide some context and understanding and background. So hopefully this discussion can be useful to you, no matter what area you're coming from. But obviously I have a limited amount of time. I'm going to try and cover the highlights. And if you are a prescribing clinician who has more nuanced questions, great, send them our way. That's part of what we're here for. So like I said, hopefully it'll be, this will be kind of high yield for you, no matter where you're kind of coming from. Okay, go ahead, Lena. And yeah, so we're going to cover some things. We're going to talk about the pregnancy and lactation labeling rule. Just talk about some general principles that we think about for our pregnant or lactating patients who need psychiatric treatment, and then just identifying some key components of what we're looking at when we weigh risks versus benefits with patients when we think about treatment during this period. Okay, go ahead. So, kind of first things first, we talk a lot about, during pregnancy when we talk about medication options for treatment. On the one side, there is the valid concern about an exposure to medication. However, again, beyond the scope of discussion today, but we do talk about this a lot in some of the trainings and outreach that we do, is that there are certainly a lot of known risks related to exposures to undertreated or untreated mental illness during pregnancy and the postpartum period. So we're really talking about, risks, risk decisions that are being discussed when we think about approaching our patients. And that ultimately no decision is without some level of risk. But we try to do the best that we can to, to inform our patients and partner with our patients in making decisions that make the most sense for them and where they are. Okay, go ahead. And then just some basic definitions. Again, when we talk about, exposures during the perinatal period, thinking about, what window of time are we talking about? So you may hear terms thrown around like teratogenicity or teratogenic effects versus adverse fetal effects. So teratogenic effects, we're kind of talking about this early exposure in pregnancy, which can cause alterations in major organ formation, such as neural tube defects, cleft lip palate, or congenital heart defects. Whereas adverse fetal effects, we're referencing exposures later in pregnancy or during the postnatal period, which can result in other things like withdrawal, difficult postnatal adaptation, things like that. So depending on what period of time we're looking at, the effects or outcomes may be different. Go ahead, Lena. And this is one of those, like if you took like anatomy or embryology, like everybody kind of gets this slide like burned in their burned in their brain. The main point, and obviously, unlike having to memorize this as some of us had to do, what I really want to focus on is a question about a medication exposure during the first, during the first few weeks or the first trimester of a pregnancy may look very different. That risk or risk benefit discussion may look very different if a patient is presenting, later in pregnancy, right? Because, particularly looking at something, if we're talking about a medication that may have a risk of, say, congenital heart malformation, that window is much earlier in pregnancy, right? That window of opportunity is much earlier in pregnancy. So again, depending on the time at which a patient presents, when we're talking about medication exposure, that risk discussion can certainly look different. And that's just kind of the main point I want to drive home here. Okay, go ahead. So I'm curious because this does come up somewhat often. First of all, I don't know if everyone is aware. I think a lot of people have heard of the FDA, ABCDX risk category system. First of all, everyone may not be aware that it has been replaced by a different system. Does anyone want to take a guess as to how long ago that was or what year this was replaced? It was a pivotal year in my life. Any takers? Okay.
I'm gonna guess 2020.
Nope. Good. 2015 was
Oh.
actually the year my daughter was born, like right around the time that this system was replaced. So yeah, 2015. It's actually been almost 10 years since this system was replaced by a newer category system that I'll talk about in a little bit. And it had been around for about 30 or a little over 30 years. It still gets referenced a lot. And even, I mean, I know people like to, look up medications or look online. Even some fairly reputable websites still reference this system. And while, it was helpful in providing some basic guidance in talking about medication risk with patients, a lot of critics, fairly argue that it was an overly simplified system, could be confusing and misleading. A lot of the decisions about which category a medicine was placed in were based on animal studies, which animal models, which don't necessarily always translate to, to human models. And a lot of these classifications were based on older or outdated studies, which didn't account for newer research and just evolving understanding of medication safety in pregnancy and lactation. I'll give you a few examples. So lithium under this system was categorized as D. Which a lot of people kind of equate to not being compatible with pregnancy. It's not to say, lithium has some data establishing it as having some associations with increased risk of teratogenicity, particularly related to heart defects. However, a lot of those were based on older data through voluntary registries from the 1970s. There have since been some more recent meta-analyses and some other studies, larger studies, that have not replicated the elevated sorry, I'm losing my words, as an elevated level of risk as was previously thought, while still there though. And a lot of studies have also pointed to a dose response relationship. So the answer is it's more nuanced, right? And then there was also this kind of innocent until proven guilty phenomenon where kind of newer untested drugs with no known harmful side effects were perceived to be safer. A great example, and I'm not poo-pooing on any particular medication. Latuda came out on the market, I don't know, 2011, and got category B designation, whereas other atypical antipsychotics, other similar medications were categorized as C. whereas we had a lot more data on them, but there weren't there were just, because it was newer, there were no known harmful side effects, and so there still seems to be kind of a preference sometimes in prescribing, something like Latuda versus other medications, which aren't necessarily incompatible with pregnancy. But it's complex, and it's a little bit more complex than the ABCs seem to imply. All right, next slide, please. So what we did switch to was the PLLR, or the pregnancy and lactation labeling rule, which got rid of the letter categories and includes a narrative risk summary that kind of better supports the shared decision making. It provides more comprehensive information derived from clinical experience, and does include some animal models, as well as concerns related to the pharmacologic activity of the drug. It includes information on risks associated with untreated illness, and provides an overall kind of more narrative risk summary that just supports this communication between clinicians and their patients. So the potential problems, again, because of kind of the length, some people might still find it confusing, or have difficulty kind of deciphering or interpreting the labeling. In fact, there was one study, it was allergists and immunologists, but this survey that they did showed that like almost half of and this was in 2020, 5 years after the PLLR came out. Half of the doctors who responded to this survey were unaware of the change to the PLLR after reading an example of the labeling. A majority felt like the narrative summary was too long, and also a significant majority, 95%, said they would continue to use the pregnancy letter category. And again, we see this and hear about it often, people still referencing the old letter system. So it's not as widely known, and doesn't get used as often. Okay, go ahead. And then we just have some general research limitations, because of, ethical considerations. Pregnant patients are often excluded from large-scale clinical trials to establish effectiveness and safety data. So the studies that we look at when we talk about known safety data or reproductive safety data often rely on observational methods such as pregnancy, voluntary pregnancy registries, smaller case control or cohort studies. So overall, smaller sample sizes, shorter follow-up periods. So it can make it kind of difficult to kind of discern and decipher definitive conclusions about long-term risks of just a lot of medications in general. Go ahead, please. So what do we know about, a lot of the medications that we use? We do know that during pregnancy in particular, a lot of these medications do cross the placenta and are present in amniotic fluid. We know that there are a lot of other dynamic changes that can occur during the course of pregnancy and can also affect the clearance and metabolism of medications. So what this ultimately means is, probably not a surprise, a lot of these patients do need close clinical monitoring, again, as their metabolism of these medications can changes. And in some cases, it's kind of sounds weird. In some cases, we may actually need to increase the dose of a medication during the course of pregnancy as metabolism actually increases. But again, individual decision-making, close clinical monitoring. Okay, go ahead. And then when we think about breastfeeding and some of the medications that we use, again, the psychotropic medications pass into breast milk, but the amount, the degree to which they do can vary greatly. And I'll give some examples of that later on. Some things that we do look at, again, kind of putting putting it into perspective, part of a big picture. Some things that we look at is something called the relative infant dose. So it's the kind of the weight adjusted percentage of the maternal dosage, or what the breastfeeding mother is getting, the percentage of that's ingested by a breastfed infant. And then we look at things like drug half-life. So, this is important for understanding the kind of the amount of time that it takes for a medication to be processed and ultimately eliminated from the body. So, a drug that's going to kind of hang around a little bit longer in the system, we might look at that differently than, say, a medication that has a shorter half-life and is eliminated from the body sooner. We also look at things like medical stability of the newborn, right? A premature infant or a medically fragile newborn may have more difficulty metabolizing and processing medications from their body. We typically don't monitor serum levels or recommend serum monitoring for infants unless there's a concern for toxicity, such as in the case of lithium. And we generally don't recommend pumping and dumping because there isn't a whole lot of evidence to kind of back it up. And sometimes, again, depending on, changes in the infant, age, medical stability, sometimes, medications might be able to be saved for another time. Go ahead, please. So again, kind of continuing on some considerations that we think about for breastfeeding. The American Academy of Pediatrics considers a medication compatible with breastfeeding if the relative infant dose is about 10% or under of the maternal dose. Again, one piece of the puzzle. A lot of people kind of rely on that, lean into it very heavily when looking at medications, and it's important, but it's one piece. So some other things that we consider, what is this mother's current severity of symptoms, how a psychiatric diagnosis may impact the ability to exclusively breastfeed. One condition that we talk about quite a lot when thinking about this is bipolar disorder, right? Which, sleep is important for everybody, but particularly with patients with bipolar disorder, what is going to be logistically possible. And especially if we're talking about a parent who's breastfeeding, that's certainly that's going to impact sleep. Potential impacts of medication on milk production. Some of the medications that we prescribe have been associated with impacting milk supply. So we want to think about that in particular when establishing breastfeeding. I talked about lithium as one example of a medication that we do recommend serum monitoring in infants. What is going to be possible? That's going to take a lot of coordination of care, particularly with the infant's pediatrician. Are they on board? Are we able to collaborate and coordinate? So those are some considerations that we look at. And again, age, medical stability of the infant, and that's going to possibly affect how this infant might metabolize medicines. And then, a newborn, a breastfeeding newborn is certainly going to, who is exclusively breastfeeding, it might be approached differently than, say, a 1-year-old who is, feeding less often and is eating solids as well. So those are some things that we consider in these cases. Go ahead, please. I'm trying to wrap up. Please don't memorize this, just examples. And Zoloft in particular, we often get asked, like, is Zoloft the safest medication for pregnancy and breastfeeding? The answer is it's complicated. And I think the reason a lot of folks, out there might favor it is because of this low relative infant dose that we see. But as you can see, a lot of medications that we commonly prescribe do kind of fall under that 10, around or under that 10% range. But again, like I said, I know I keep saying it. It's one piece. It's one piece of the puzzle. So keep that in mind. Okay, go ahead. This is kind of like my if you don't remember anything else, I like I loved it. Just when we think about some general approaches, we want to try and avoid abrupt discontinuation of medications during pregnancy and breastfeeding, particularly if it's what's kept someone well. Aim to minimize the total number of exposures, but we also need to think about symptom stabilization, right? If a particular regimen has kept a patient well, we typically don't recommend stopping an effective medication in favor of a perceived safer medication, with some exceptions, such as valproate or Depakote, which does have, well-established significant risks of teratogenic effects. So that's why it's in bold red. In fact, I typically don't recommend that anyone of reproductive age or potential be placed on that medication if we have reasonable alternatives. Want to think about weighing risk benefits, not stopping a medication if we don't have a plan in place for their continued well-being. We want to use the lowest effective dose and treating to remission. Maximize non-pharmacologic support. So again, that's where a lot of our other supports, therapists, home visitors, can be huge allies in putting all the pieces together and making sure that we do have some other supports in place. Thinking about, of course, patient choice and coordination of care. And then when we can get it, it doesn't happen often, but if we have a window of opportunity to meet and discuss some of these risks with a patient before they get pregnant, that's amazing. That's my favorite type of of evaluation to do, but we know that's not always possible. Okay, go ahead. I'm going to we kind of talked about some of this already, just some factors that we weigh again when thinking about decision making regarding continuation of medications or establishing medication treatment during pregnancy. And then go ahead. And I think that's the last slide. So just some other resources for shared decision making, mother to baby, I think great kind of lay friendly fact sheets for patients and families, not just for psychiatric medications, but all sorts of medications. LactMed is kind of has a lot more scientific medical jargon. So I usually tell people, be kind of careful there. MGH Center for Women's Mental Health and Infant Risk, I think can also be great sources for shared decision making. And I think that's it. Sorry if I went a little over.
No, thank you so much, Dr. Vincent. I really appreciate that wonderful presentation.
Yeah, absolutely. So thanks again, everyone, for participating in this session today. Big thank you to Dr. Vincent for presenting a great didactic. And thank you, Anna, for the very interesting and complex case. And we hope some of these recommendations can kind of help guide treatment planning in the future. But I did drop into the chat the link for the CEUs, CMEs, and CEs. The link is active for 72 hours. We will be sending an email with that same link, so don't feel like you have to hurry up and click it. We'll also send out the recommendations to all of the participants for the case, so you have it in your back pocket. And we will also post the didactic through the iEcho platform. So again, thank you guys for joining. We will see y'all next month, next Tuesday. Next session is Tuesday, May 27th from 12 to 1. And we have Bess Hart presenting on perinatal mental health in non-birthing partners. Again, thank you all for coming. We hope you have a great day.